इसको रिफ्रेश करो उधर से, सिस्टम से, लैपटॉप से करो। यस काइंडली आप सब जो है वो अपने मोबाइल से इंटरनेट डिस्कनेक्ट कर दें ताकि ये फिर लाइव ट्रांसमिशन चल सके। थैंक यू। क्या कह रहे हैं सर? सर वो नीचे ये सब ऑपरेट कर रहे हैं। अल्हम्दुलिल्लाहि रब्बिल आलमीन, अस्सलातु वस्सलामु अला सय्यिदिनल मुरसलीन, अम्मा बअद, फ़अऊज़ु बिल्लाहि मिनश शैतानिर रजीम, बिस्मिल्लाहिर रहमानिर रहीम। अपनी इस तकरीब का आगाज़ बाकायदा अल्लाह के नाम से करूँगी। बिस्मिल्लाहिर रहमानिर रहीम। आज की इस तकरीब का मकसद मैं निगम आदिल, मीडिया असिस्टेंट, FIO हॉस्पिटल, मीडिया एंड इंफॉर्मेशन डिपार्टमेंट FIO की तरफ से आप सबको खुशामदीद कहूँगी। आज की इस तकरीब का मकसद पूरी दुनिया में फरवरी लो विजन अवेयरनेस के तौर पर मनाया जाता है। इसी हवाले से आज हमारे साथ इस सेमिनार में बहुत ही मुअज़्ज़ज़ और काबिल एहतराम मेहमान भी मौजूद हैं, जिसमें मिस यमुना तारिक, डॉक्टर अंसा बेनज़ीर एंड और रिस्पेक्टेड डॉक्टर मुश्ताक अहमद हमारे साथ आज इस तकरीब में मौजूद हैं और यकीनन आज की इस तकरीब को हमारे लिए मज़ीद खूबसूरत बनाएंगे। सबसे पहले मैं दावत देना चाहूँगी मिस्टर आरिफ को, जो कि FIO हॉस्पिटल पेशावर के ऑप्टोमेट्रिस्ट हैं। वो यहाँ पर आए और आकर कॉजेज़ ऑफ लो विजन पर अपनी प्रेजेंटेशन हमारे साथ शेयर करें। मिस्टर आरिफ।
औज़ुबिल्लाहिमिनश्शैतानिर्रजीम बिस्मिल्लाहिर्रहमानिर्रहीम रब्बि इश्रह ली सदरी व यस्सिर ली अमरी वहलुल उक़दतम मिन लिसानी यफ़क़हू क़ौली। My name is Arif and working here as an optometrist, and today the topic of my presentation is the causes of low vision, introduction and causes of low vision. आज के हम इस लो विजन अवेयरनेस मंथ में हम इंशाल्लाह इस जो सेशन हमने अरेंज किया है उसमें से हम इंशाल्लाह इन चीज़ों के बारे में नॉलेज ऑब्टेन करेंगे, जो कि इंट्रोडक्शन में हमारे पास काजेज़ ऑफ विजुअल इम्पेयरमेंट, स्टेप्स ऑफ असेसमेंट और उसके बाद जो है मैग्नीफिकेशन, उसकी मैनेजमेंट जो है उसको हम किस तरह मैनेज करते हैं। तो फर्स्ट ऑफ ऑल लो विजन क्या है? लो विजन की डिफिनीशन जो है, अकॉर्डिंग टू वर्ल्ड हेल्थ ऑर्गेनाइजेशन जो है, ए पर्सन विद लो विजन एक बंदा जिसकी विजुअल एक्यूटी लेस देन 618 हो या विजुअल फील्ड लेस देन 10 डिग्री फ्रॉम द सेंटर ऑफ फिक्सेशन जो है, तो उसको हम लो विजन में कंसीडर करेंगे। लेकिन अगर हमने सब कुछ उस पर ट्राई किया हो, बेस्ट पॉसिबल सर्जिकल, मतलब जितना भी हमारे पास वो हो, उसके बावजूद भी उसकी विजन 618 से कम हो या विजुअल फील्ड जो है 10 डिग्री लेस देन 10 डिग्री फ्रॉम द सेंटर ऑफ फिक्सेशन, तो अकॉर्डिंग टू वर्ल्ड हेल्थ ऑर्गेनाइजेशन उसकी डिफिनीशन ये है। अच्छा, तो इंटरनेशनल क्लासिफिकेशन ऑफ डिजीज़ जो है ICD-11 के मुताबिक जो है, उन लोगों ने विजुअल एम्पेयरमेंट के डिफरेंट वो किए हैं, कैटेगराइज किए हैं कि नॉर्मल विजन किया है तो वो 6 है, और जो माइल्ड है वो 612 to 618, और जो मॉडरेट टू सीवियर है वो 618 से लेकर 3/60, और जो ब्लाइंड है वो 3/60 या लेस देन 10 डिग्री। तो जो अकॉर्डिंग टू इंटरनेशनल क्लासिफिकेशन ऑफ डिजीज उसमें से जो मॉडरेट और ब्लाइंड है वो लो विजन के कैटेगरी में आते हैं। तो वो लो विजन की कैटेगरी में आते हैं, और जो नॉर्मल है या माइल्ड है वो लो विजन के कैटेगरी में नहीं आते अकॉर्डिंग टू इंटरनेशनल क्लासिफिकेशन ऑफ डिजीज। तो ये इंटरनेशनल क्लासिफिकेशन ऑफ डिजीज़ के मुताबिक जो मॉडरेट और ब्लाइंड है वो लो विजन की कैटेगरी में आते हैं, लेकिन जो नॉर्मल और वो है माइल्ड सीवियर माइल्ड विजुअल इम्पेयरमेंट है वो लो विजन की कैटेगरी में नहीं आते। तो उसके बाद जो हमारे पास मेन काजेज़ है, तो उसमें हमारे पास कंजेनिटल आई डिजीज़ जो है वो हम एक एक को फिर बाद में इंशाल्लाह एक्सप्लेन करेंगे। और जो इनहेरिटेड आई डिजीज़ है जो लो विजन को काज करते हैं, वैसे तो काफ़ी उसके मतलब वो है काजेज़ है, लेकिन जो मेनली हम उसको कंजेनिटल और इनहेरिटेड और रिक्वायर्ड के बेस पे हम करते हैं। तो उसके जो काजेज़ है वो एक एक हम करते हैं कि कंजेनिटल काजेज़ ऑफ लो विजन जो है उसमें एल्बिनिज़म है, कैटरेक्ट है, ग्लाकोमा है और एक क्रोमेटोप्सिया है। तो ये कंजेनिटल काजेज़ है जो बाय बर्थ जो है उसमें ट्रांसफ़र होते हैं। और उसके बाद जो है इनहेरिटेड डिजीज़ में रेटिनाइटिस पिगमेंटोसा है, ऑप्टिक एट्राफी है, और स्टारगार्ड डिजीज़ जो है वो एक और भी मतलब उसमें से इनहेरिटेड डिजीज़ में से आते हैं। और फिर उसके बाद एक्वायर्ड डिजीज़ जो डिवेलप आफ्टर बर्थ, मतलब पैदाइश के बाद जो है वो डिवेलप होते हैं, तो उसमें ग्लाकोमा है, आई इंजरी है, रेटिनोपैथी ऑफ प्रेमेच्योरिटी है, और सेरिब्रल या कार्टिकल विजुअल इम्पेयरमेंट है। जो कंजेनिटल आई डिजीज़ है उसमें एक्रोमेटोप्सिया जो कलर ब्लाइंड जिसको हम कहते हैं, तो वो हमारे पास कंजेनिटल आई डिजीज़ हैं जो लो विजन को काज करते हैं, मतलब जो लो विजन के मेन काजेज़ में से आते हैं। और दूसरा है एल्बिनिज़म, और तीसरा है रिफ्रैक्टिव एरर्स, ओपेसिटीज़, मीडिया ओपेसिटीज़, चाहे वो कंजेनिटल कैटरेक्ट हो या कार्नियल ओपेसिटीज़ हो, तो जो या एम्ब्लायोपिया हो, तो ये जो चीज़ें हैं ये कंजेनिटल आई डिजीज़ हैं जो उसको काज करते हैं। अब रेटिनोपैथी ऑफ प्रेमेच्योरिटी को अगर हम देखें तो एक हर वो बेबी जो प्री टर्म डिलीवरी हो जाए, मतलब उसकी 9th मंथ पे उसकी पैदाइश ना हो जाए, उनसे पहले हो जाए, तो उसको हॉस्पिटल में एडमिट करते हैं। जब हॉस्पिटल के आईसीयू में एडमिट करते हैं तो उसकी वेट को पहले वो करते हैं, मेजर करते हैं। अगर उसकी वेट कम है तो फिर डॉक्टर डिसाइड करते हैं कि इसकी या तो लाइफ को इम्पोर्टेंस देनी है या उसकी विजन को। तो उसको ऑक्सीजन लगा लेते हैं तो उसकी लाइफ जो है वो तो मतलब सेफ हो जाती है, लेकिन उसकी रेटिना के लेवल पे जो वो चेंजेस है और डिटैचमेंट्स है तो फिर वो आना शुरू हो जाते हैं। और डिजीज़ का सेंट्रल विजन अब ये है कि कुछ ना कुछ जिस तरह हमने डिफिनीशन में पढ़ा कि लो विजन जो है 618 से विजन कम हो या विजुअल फील्ड, तो कुछ डिजीज़ इस तरह है कि हमारे सेंट्रल विजन को ख़राब कर देते हैं, और कुछ डिजीज़ इस तरह हैं कि वो हमारी पेरिफेरल विजन को ख़राब करते हैं। तो वो डिजीज़ जो हमारे सेंट्रल विजन को लॉस करते हैं उसमें से एज रिलेटेड मैकुलर डिजेनरेशन है, स्टारगार्ड डिजीज़ है, एंड विट्रियल फॉर्म है। एज रिलेटेड मैकुलर डिजेनरेशन में हमारे पास प्रोग्रेसिव एक्यूमुलेशन ऑफ कैरेक्टरिस्टिक येलो डिपोजिशन जो है वो आ जाते हैं, और फिर उसके बाद उससे ड्रोजन, स्पेशली मैकुलर एरिया में हमारे पास ड्रोजन की फॉर्मेशन होती है। फिर उसमें अगेन अगर हम डिटेल में जाना चाहें तो उसमें से 2 टाइप्स है, ड्राई एएमडी है और वेट एएमडी है, तो उसकी अपनी मैनेजमेंट फिर उसी के मुताबिक। लेकिन ये है कि ये लो विजन को मेन काज जो है लो विजन की तो उसमें से आती है ओल्ड एज में। और फिर उसके बाद स्टारगार्ड डिजीज़ है। स्टारगार्ड डिजीज़ जो है इनहेरिटेड डिजीज़ है, लाइट सेंसिटिव सेल्स जो है उसको हमेशा के लिए वो कर देते हैं। और जो पेरिफेरल विजन है मैकुलर एरिया में जो वो विजन है वो ख़राब हो जाती है, और मोस्टली केसेस में जो विजन की साइमेट्री होती है वो मतलब एसाइमेट्री नहीं होती। अगर फॉर एग्जांपल एक पेशेंट आ जाता है और उसकी एक आई में विजन है 624, तो उसकी दूसरी आई में मोस्ट ऑफ द केसेस जो मैंने जो है आरपीई डिजेनरेशन, आरपीई के लेवल रेटिनल पिगमेंटल एपिथेलियम जो है उस पर डिजेनरेटिव वो आ जाते हैं, और ये भी सेंट्रल विजन को लॉस करते हैं। और मेनली जो मेटामॉर्फोप्सिया जो है इमेज की डिस्टॉर्शन, और ये उसमें से आ जाते हैं। स्कोटोमा जगह जगह पे पेयर हो जाते हैं। डिजीज़ जो है वो हर जगह पर मतलब अपने अब ये है कि अगर फॉर एग्जांपल सेंट्रल एरिया में है, मैकुलर एरिया में है, तो सेंट्रल स्कोटोमा, जिसको हम फिर बाद में वो अकॉर्डिंग टू विजुअल फील्ड हम कहते हैं कि ये रिलेटिव स्कोटोमा है, ये एब्सोल्यूट स्कोटोमा है, ये आर्कुएट स्कोटोमा है, जो डिफरेंट डिजीज़ में मतलब डिफरेंट उसके पैटर्न के साथ बनते हैं। तो डायबिटिक में ये है कि जहाँ पर भी मतलब हमारे पास हेमरेजेस आ जाएँ और वो उसमें से क्लाट हो जाएँ और उसकी सप्लाई जो है वो इंटेक्ट हो जाएं तो उसमें से वहाँ पर स्कोटोमास जो है वो बन जाते हैं। टोक्सोप्लाज्मोसिस में भी इसी तरह के मतलब मेकुला के इर्द गिर्द जो या हिस्टोप्लाज्मोसिस में भी हमारे पास जो स्कोटोमास बनते हैं तो उसके मुताबिक जो फील्ड में आपको प्रेजेंट करते हैं पेशेंट के मतलब ये तो अब डायबिटिक रेटिनोपैथी है तो डायबिटिक रेटिनोपैथी जो है मतलब किस तरह वो चेंजेस आते हैं। तो डायबिटिक रेटिनोपैथी में जो टाइम के साथ साथ जिन लोगों का डायबिटिक कंट्रोल नहीं होता तो उसमें से ब्लड मतलब जो ब्लड वेसल्स है उनसे ब्लड निकलना शुरू हो जाते हैं और कभी कभार जो है रेटिना की ब्लड सप्लाई सेंट्रल रेटिनल वेन ऑक्लूजन या ब्रांच रेटिनल वेन ऑक्लूजन या वो हो जाते हैं तो उसकी वजह से जो न्यूवास्कुलराइजेशन स्टार्ट होना शुरू हो जाते हैं। जो न्यूवास्कुलराइजेशन होते हैं तो उसके जो ब्लड्स के जो वो होते हैं रगे होते हैं वो बारीक होते हैं बिल्कुल। तो उनसे जो बार बार जो है ब्लड आना शुरू आते हैं, बार बार ब्लड लीकेज आते हैं तो उसकी वजह से हमारे पास जो कंट्रास्ट और विजुअल फील्ड जो है वो एट द एंड जो है वो इफेक्ट करते हैं। और उसके साथ साथ जो है केराटोकोनस है। केराटोकोनस जो है अब इसकी मैनेजमेंट अब अगर फॉर एग्जांपल माइल्ड लेवल का केराटोकोनस है और आपने उसको अर्ली डिटेक्ट किया तो वो विजन को तो काज नहीं करते। लेकिन अगर एडवांस केराटोकोनस ट्रायल दे दें और उसके साथ भी उसकी विजन जो है वो इम्प्रूव ना हो जाए तो वो जो है एट द एंड या तो हम केराटोप्लास्ट या चीज़ें तो ये है कि मतलब ये भी एक लीडिंग काज है फॉर लो विजन। और उसके साथ साथ रेटिनल डिटैचमेंट है जिसके मतलब डिफरेंट फीचर्स होते हैं कि रेटिनल डिटैचमेंट में हमारे पास
बहुत शुक्रिया मिस्टर आरिफ। अब मैं दावत देना चाहूँगी डॉक्टर अंसा बेनज़ीर को कि वो यहाँ पर आएँ और आकर जो है वो लो विज़न के हवाले से जो है वो उन्होंने लो विज़न मैनेजमेंट के हवाले से प्रेजेंटेशन तैयार की है वो हमारे साथ शेयर करेंगी।
Bismillahirrahmanirrahim. My name is Ansa Benazir and I work as low vision therapist at Khyber Teaching Hospital. Thank you, Arif, for the causes of low vision. And as we all know the different causes, Arif explained that some of the diseases causes central vision loss, some causes peripheral vision loss. So the management of diseases depends on the vision of the patient and on the field loss of the patient. So today we will see what low vision is, what are different steps of rehabilitation or how we can rehabilitate the patient. Then we will discuss different low vision devices. So what low vision rehabilitation is, first we will see what low vision is. If the best corrected visual acuity of the better eye. See, if the patient has one blind eye and other is 6/6, he is not the low vision patient. The low vision patient is one which have 6/18, worse than 6/18 in the better eye. This patient is considered as the low vision patient. Or in another case, if the patient visual acuity is 6/6, but his or her visual field is less than 10 degree, this patient is again considered as low vision patient. What we do in rehabilitation is we use the residual vision of the patient, and with the help of low vision devices, magnifiers, telescope, electronic devices, we bring the visual, the image, we enlarge the image so that it reaches to the parafoveal area, which is marked in this picture, that we bring this image into the parafoveal area, and thus the patient is able to see because it is the healthy part of the retina. If in any case the patient is blind and he is not able to use the low vision devices, we go for the orientation and mobility training. So how we manage the patient, we have to, when the patient enters our clinic, we have to look at the gait of the patient, his appearance, his socio-economic status. We have to take the complete case history of the patient, starting from the name, his age, because some devices are age specific, some devices are need assessment. We have to go for the need assessment. If the patient is not literate, there is no use to give them magnifiers because it's of no use for them. But if the patient is literate and he want to recite or read, we have to give the magnifiers or telescopes. Telescope for viewing the distance and magnifiers for the near. But if the patient is cannot move or he's at one place, then we don't need to give them such devices like Ocotec that he have to wear them and with mobility. These some devices are for mobility purposes, some are for stationary purposes, some are for.
As you said, we all those patients whose visual acuity is less than
618. What's
the visual field is less than 10 degree. All these patients considered to be a low vision patient. So this is for both eyes.
This is for both eyes. If the visual acuity of the patient is 6.6 and his visual field is less than 10 degree.
If
So
the one eye vision is 6.6,
both eye vision.
if the one eye vision is 6.6,
Yes.
one eye is less than 6.18, this patient will not be considered as a low vision.
Yes, this will not be considered as low vision patient.
Okay. So for low vision, we will consider all those patients whose both eyes vision is less than 6.18.
Both eye vision is less than 618 after correction of glasses, after available possible treatments, surgical treatments, contact lenses and glasses. If still the patient has visual acuity, yeah, best corrected visual acuity less than 618, they are considered as low vision patient.
I want to add something there. The thing is that if one eye is 6.6, but if you take visual field, which is a binocular phenomena, so if the visual field is then less than 10 degree, then this is considered as low vision patient, despite of the fact that he or she has a visual acuity of 6.6 in one eye, right? So there is, I just wanted to add this here.
Thank you. Can you correct the mic or answer? Because I think her mic is not working.
This is not the last mic.
Okay.
Okay, so we, when we examine the patient, we have to check the need assessment of the patient and then we make target for ourselves. Like we set goals. Either we have to give the magnifier, either we have to give the telescope, or we have to give the both. Or we have to give the electronic low vision aid, or we have to go to the rehabilitation, that is orientation and mobility session. After setting goal, we go for the visual functions. We test visual acuity, color vision, visual field, contrast, and refraction, retinoscopy. These all comes under the visual function tests. Then we go for the trials. Starting from the refraction, like we have to re-refract our patient. Even if it is refracted, even if patient come to you, we have to repeat the refraction. Then we will go for the trial telescope, and depending on the need of the patient or what we have set the goal, telescope, it can be telescope, it can be magnifier, and we will train the patient, and thus in the end we will prescribe the our prescription depending on the telescopes and magnifiers and non-optical. There is a long list of low vision, like if we go for the approach magnification, for magnification of the letter, or large prints and changes in the room, they all come under the non-optical devices.
And we have only, I think we have only optica.
We have in FIO, yes, we have FIO, optical devices.
Other than optical are available in HMC or KTH or near.
Electronic vision aids are available at KTH and HMC, and other than these are large print keyboard we have at KTH, and I don't know if Yumna can add anything from HMC. In optical devices, we have telescopes, magnifiers, telescopic contact lenses, miniature telescopes, and so Abdullah was asking me why I pasted this bus picture. So this was, people went on vacations, and we travel a lot in the buses with visually impaired blind patient also, but they cannot see the bus number. So only good use of these telescopes for those patients is monocular telescopes, because no one can hold monocular telescope for the whole day. What is the solution then? Binocular telescopes. Monocular telescopes are not kids appropriate. They cannot hold the monocular telescope in their classroom and then copy from the board. So these binocular telescopes are for kids appropriate. They can watch, and these telescopes, they are Galilean and spiral, and FIO we have. They can be used both for near and distance. When you groove it, you can use it for the near and re-groove it back to the original place. They work for the distance. So they are very good for the kids. But the problem here is they are only available in 3.5x to 3x, 3.5x. Then there were causes, cosmetic issues. No one wants to use glasses. Then how can they be accepting to use telescope? But nothing is better than something. Something is better than nothing always. And these are the cosmetically appealing and budget-friendly telescopes. Honeybee's lens system, it is triple telescope system in which 3 telescopes of same power are aligned optically so that the light is directed to the center of the eye. How it is directed? There is a specially designed wedge-shaped prism on the telescope, outer side of the telescope. And can you point over the outside of the... This pointer is not working on LED screen. So, on outside of the, yes, here, it is a wedge-shaped prism which directs the light to the center of the central telescope. Okay, now on this biomicro EF, this is the Keplerian design telescope. It is for mobility. Most of the telescopes were not good for mobility. Telescopes are good for mobility, but they are not for the near use. The next is spiral Galilean telescope. This is as we have in FIO. They work for distance as well as for near. The purpose of these telescopes are these are cosmetically more appealing. Next. This telescope is 4.4 millimeter in its size, and it can be easily implanted. It is available on centrasite.com.
Have you seen this
Yes.
telescope in fashion?
And yeah.
So, I think the main problem in using low vision aid is cosmesis. Because people will, I think, regret it if they see the shape and the weight of such
Yes.
type of optical
Yes.
telescope. So this is a very practical thing if we implant the miniature telescope inside the eye
Yes.
in place of lens. So
It is 4.4 millimeter in size,
okay.
and the natural lens is removed, and it is placed where you place the natural lens. And
Yes, but this is, I think,
for
this
the
is
healthy,
simple.
when it is for the end stage AMD diseases,
Yes,
it is
especially
placed.
in AMD cases.
AMD cases, end stage AMD cases, when there is peripheral retina is healthy.
Yes.
There is no other disease, like no comorbidity like diabetic, there is no issues and no hypertension.
Implanting such a means 4 millimeter. It will be thick 4 millimeter or it's
Thick.
The 4 interior chamber depth is 3.5 millimeter.
Yes.
So there is a high
Yes.
useful Very practical.
Its power ranges from only to 3.0x, like it's 3x, and the problem is it would be implanted in one eye. So the patient would use one eye for near work or for distance, and the other eye would be left for
Yes.
checking the distance. So patient has to adopt to the condition. It would need a post-surgery training also. So contact lens telescope.
Can you show the picture of a miniature telescope?
Yes, it was on the top. That, oh, sorry.
The second one on the finger.
Yes.
This is like a lens. They have a haptic, they have a optic, but the optic is so big to get it. This one. So, जी कार्निया में बिल्कुल 3D, yes. But on the finger, on the top, you can see the picture of miniature telescope. I have presented this case
Yes.
on presentation on this low vision
Yes.
as well. Okay.
Can we go back?
Okay, thank you.
So this is the cosmetically appealing condition when we can use -10 contact lens along with the high +8 to +16 glasses. So this is a condition in which we can give 1x or 2x or 2.5x. The patient can use this contact lens, and this is cosmetically a little better. There are some other contact lenses, but they were thick, 1.7 millimeter on the internet, and there were 2 layers and polarized glasses to be worn with them, and they were not much attractive to me. Then I thought it would not be attractive to the patients as well. But I like this idea. So magnifiers. This all was about telescopes. Now we are shifting to the magnifiers. In magnifiers, we have different types of magnifiers: illuminated magnifiers, non-illuminated magnifiers, flat surface magnifiers, stand magnifiers, and pocket magnifiers, and there is a long list of magnifiers. So if the patient is unable to hold the magnifier, we shift either them to the stand magnifier, or if his vision is better, we shift them to the flat surface magnifier. This is called the bar magnifier, and the patient can read the whole complete line. I have not added all the magnifiers, sorry, it's okay. These are the designforvision.com specialized glasses, which is a solution for cosmetic causes of the magnifiers. If someone is very cosmetically concerned, these glasses are high plus. We can see from prismatic to piece. In this, there is the high index lens, which is 1.76. Normal index is 1.56. And normally available in high index contact lens, these glasses in Peshawar are 1.6. But these are 1.76 high index lenses with high plus power. And to decenter, there is prism. Like 2-piece, it is, one is high index, high lens, high plus power. And the second is prism, which decenters the vision. And the convergence is not induced. The second is microscope. In this, only there is no, it power ranges 2x to 8x, and there is no prism in this one. Here, if Amir can point it. Sorry. It's the microscope 2x to 8x. Yeah, this one. You can see thickness in one side and other side is plain. So to avoid the thickness of the lens, the patient has the idea of monovision. Next, we have these 2 telescopes, telemicroscope and higher power microscopes. They are same high plus lenses in the plastic housing, and they work as microscopes, but they are of cheaper cost as compared to the other previous old designs. On the other side, we have biomicroscope. No, that bifocal microscope. These are the high plus, high index lenses, and the patient's cylindrical reading can be incorporated in it. And but it is high index for distance, and bifocal is also in the high index number. so the thickness is reduced. Like the A text is 8 fours are 32. It's 32 diopter lens, but it looks like the normal glasses. These other are the magnifiers of like normal magnifiers. We all have seen them. When magnifiers are not working due to the reason of patient's visual acuity, we shift these patients to electronic devices. And electronic devices work by the principle of transverse magnification of an image. So they are of different types. They are of desktop, which is CCTV, portable, in shape of like tablet forms, electronic visual enhancing systems, and head mounted. We'll go for the explanation in the next slides. So where I have to direct it. Desktop video magnifier. They magnify the image. They are fixed on one place, and there is adjustable color contrast and brightness, and they can be used for personal grooming. This one is portable, and it is good for the school-going children. There is a research done that visually impaired children can benefit more from the combination of perceptual learning. Usually the visually impaired children, they go only for perceptual learning with electronic visual aids. Then perceptual learning is like the text is read aloud for them, and they hear that text and they remember it. But memory works very good when you see the thing. So these magnifiers work very good for such conditions when they have good electronic visual they have good electronic visual aids, and these devices are portable. So the other one in that picture, it is only for near, but this side it can be used for distance and near as well. You can see the camera over here. It will capture the distance object, and this here he can place his copy and read for near. And that one is portable. It can be kept in pocket anywhere. Hand scan cameras with TV. There is a camera there is a mouse in the kid hand, and there is a small camera underneath this mouse, and it is connected to the desktop. It is very cheaper than the other CCTV cameras. And you can see the details over here. This is the head mounted. It is just like the VR. You have seen this maybe, the way you are moving your head. Okay, so here we have a phone, just a mobile phone. It captures whatever it is in the front of it, and it brings closer to the eye. There are two designs for this, Iris Vision and Zoom X A-side. Okay, if the patient is not able to see with electronic vision aid, so this patient is seriously or severely visually impaired, then we go for the OCR devices, which is optical character recognition. They read aloud what is written on the paper. The patient can see as well as hear but for that patient it is necessary that his or her hearing is good. In Usher syndrome, we cannot advise this thing because they have the hearing difficulty. ORCAM. Again, this is not for those who have hearing problems, but this is for totally blind people. They have two designs. ORCAM Read, it is the cheaper one, and it is only for reading. ORCAM My Eye, it detects currency, face recognition, color, and handwriting. And it recognizes almost everything once you activate it. But they are on $4,000. Okay, so for as the things are changing and everything is advancing, there are apps in mobile phones that visually impaired patient can use. You can go for simply changing to zoom and magnifier in your mobile to the different KNFB reader. It converts the text into braille. It is special mobile for blind people. that changes the text into the braille. Then we have seeing AI. It is artificial intelligence. You can use it in simple mobile phones, which regular phones, and you have to bring it in front of the object, just like the camera, and it will read aloud what is in front of the camera. Tap Tap See and Be My Eyes, they both work. They all three, Seeing AI, Tap Tap See and Be My Eyes, all three are free and can be used in the same way. Computer softwares. So people are using computer, and if you have ever visited the blind school, they're very good at computers. So JAWS, this is Spoken Web. JAWS is a paid CD. You have to purchase it once. But Spoken Web and Web Anywhere, they are both free, and they read anything on the screen for free. This third thing, it is the 3D printer, and it is used in blind schools. You can see the heart picture over here. It is printed in a 3D design, so the child can feel how can the heart would be. And everything. We visited the blind school in Islamabad, and the kids were very easily designing mountains. There were 3D mountains, and they were telling these are mountains. So these 3D printers are for totally blind people. Sorry. Smart assistive technologies for the blind people. Buzz clip, sonoband, and smart can. The regular can, there is a problem with the regular can. Okay, it can tell us where the stairs are, where the depth is, where the height is, but they cannot tell where, if the tripod is somewhere, the patient go and smack into the, this area is empty, not this one. If here are bystanders, this area is empty. The patient will check with the white cane, and he will go and smack into this, because his cane was telling this area is empty, but his cane was not telling that this area you have something over there. Sonoband and these smart canes and this buzz, they produce sonar radiations, which when the patient is going 1 meter closer to the thing, it starts vibrating. Because the sonoband should be placed over his shoulder, and it gives you shoulder height vibrations. This buzz clip. Sonar band is on the hand, and it also gives you the radiation on the floor and up to the height. And smart can also work the same. These all three are the solution for the head injuries or the injuries due to the white canes. But obviously, this all have their own limitations, because sonar band will never let you know if you are going into stairs, if you are only using it. If the patient have the glare complaints, night driving, it's not for low vision patients, all low vision patients. The most common complaint we receive is, I have the problem driving at night. I cannot face the lights from the other side. The yellow light filter is for those people, drivers. The other pink and this 88 and 570 glare shield, these are for AMD patients. I have worked on it, and they're very happy with this, because I don't know what the phenomena this for AMD specifically, but they were very happy with this one. Other shields are for albinism and patient with high photophobia patients. So we will summarize it. Which devices are for which type of visual acuity. For moderately visually vision loss or visually impaired patients, we go for the optical LVDs, CCTVs, and mobile magnifiers. But for severely, in which only optical LVDs are not working, we will go for CCTV and OCR and portable video magnifier. For blind, we go for smart canes, OCR devices, and mobile apps. Thank you everyone for your so much attention.
Thank you so much, Dr. Ansa, for such a phenomenal presentation. Now, I would like to call Ms. Yumna Tariq, who is a low vision specialist, to please come and share her views about today's event. Ms. Yumna Tariq.
Bismillahirrahmanirrahim. Thank you so much, FIO, for inviting me to give my review on today's presentation. Obviously, these were too informative, and it is just to bring awareness among the population, like the trainers or the optometrist or the ophthalmologist, or even just simple doctors or other clinicians who can bring awareness and among the society and even among themselves. Arif presented on the causes of low vision, which is very, very important to understand, to know that, because if you don't know the cause of a low vision, a patient has come to you, and if you don't know what disease he has or she has, you cannot manage it, you cannot treat them, right? So the cause of the low vision is very, very important, right? So what you have to do, being a clinician, despite from going for a long list of making a list of the causes of low vision, you can simply understand two things, that is, one is progressive diseases and stable diseases. So in that basis, you can easily go for the management side of the low vision, right? So what you have to do is to just make a list in your mind about the progressive diseases and stable diseases. Like we know RP is a progressive disease, like we know that the Stargardt is a stable disease somewhat, right? So this is diabetic retinopathy. If we talk about, if nothing is under their control, they are not using their medication and that all, so what you have to do is to wait for the stability of the patient. Until and unless he is stable, then we will go for the intervention of low vision devices, right? Coming towards the he talked about the congenital, similarly inheritance diseases and acquired diseases. So they are very important to know, because in the congenital diseases, obviously you again have a choice if it is progressing and if it is not progressing, right? If it is stable and if it is not stable. He talked about the ROP, retinopathy of prematurity, which is project is running in the KTH under the supervision of Dr. Siadia CT, and they are working on this, and obviously WHO, it's from the WHO side. So let's see and wait for those patients when they will be able to come to the low vision clinics, right? So yes, this was one of the main point I noted in the RF's lecture, and that was very important, right? Okay, coming towards the similarly infectious diseases, right, which do occur during the delivery time or before that, take it to the mother, due to which they get infection. So obviously you have to screen those all patients for toxoplasmosis and other infectious diseases, if the child has gotten that or not. We have a lot of people, low vision patients, who do come with a toxoplasmosis scar and they progress. So in that case, what we have to do is to again wait a little. We refer them for some labs under the supervision of our doctors, ophthalmologists. So after labs, if that is stable and the values are accurate, and if not, they have to take the medication, and after that they can come for the low vision management, right? Okay, globally it is accepted that 618 is the less visual acuity, which is less than 618 is regarded as you can say low vision, right, or visual impairment. Nowadays it has turned towards the 612, because in the 612 even somebody is unable to read. Now I would just to add something to the RF lecture, if you don't mind. I would like to say that kindly add near visual impairment in this definition too, because now the definition has changed from distance to near to. So visual acuity of the near also matters a lot, because if somebody is near visually impaired, he or she may also need near visual devices, right? They also need illuminations and so on, right? Okay, now coming towards Ansa, we have she talked about the management of the patient with low vision, right? So yes, we have a lot of patients we receive. She's practicing in KTH and I am here in HMC. Being working then 7 years with the low vision people and low vision children,
I have noted that the need should be identified for the patient and by the patient, right? And it is your job to identify the need. It's not just to magnify a thing. It's not just to see, to make them able to see. No, just go and identify the need. And how can you identify? By taking interview. You should be very friendly with them. You should talk not like a common man or what is the problem with you? Samasala dadarta. No, just start from what is your name. Obviously it is written on the prescription pads, but no, start from name, from where did you come, tell me from the start what happened. And obviously they have traveled long for their diseases, for their management, for their problem. They are depressed too, right? So by managing the patient, don't forget that they are depressed too. If you are also treating them when he has already passed from 10, 20 people, so there is no difference between you and the past people. So they are depressed, they are visually impaired. Along with that, they are sitting idle in their life and they have just quit their wishes. So need is to be identified. I repeat again, need should be identified. If a person he don't want to see but his concern, the primary concern is to read a newspaper, go for newspaper. Manage him for reading a newspaper, manage him for reading Quran Sharif, manage him for seeing his watch, right? And if he's saying that no, I am not, I am an illiterate, I am not an education, I don't even have read the Quran Sharif, I just want to see people look around. Yes, you can go for the distance telescopes then, right? But again, I would say that it's not just to bring the magnification. You have to take care and talk about illumination, right? Sometimes magnification wouldn't work alone. Illumination too is required. Similarly, most of the patient, they wouldn't need illumination, high illumination, even though they would like to reduce this dim light too, right? So brightness, illumination, magnification, three things are working together. And at the end, counseling, a very, very proper counseling, right? Counseling and again, training. So training is important. Whichever device you do, either for distance or either for low vision, whenever they purchase it, just tell them, come back to me, I will train you. And that training takes 45 minutes, right? I do it by myself when they purchase it, or if they receive from any funded authority, they just come to me, back to me, and I just train them after getting the telescope. Because what I am doing is I have trial kits which are applied on each and every patient, and you know that when you have your own thing, how you will use it, this is necessary. I have seen and I have received too many patients, they have just given the device, they don't know what to do with this now. They have kept it in the, you can say, bags for long life, and then when they come to me, yes, we have, but we don't know how to use them. So utility is again important. Once you have to perform by yourself in front of them, and then you tell them, pack them back and just give them, now you do it. Okay, now the training way is you have to read the chart diagonally, obliquely, then start from the right, then start from the left if you are using distance telescope, any sort of telescope, right? So start from the right, then from the left, start from the bottom, go up, right? Start from the top, go down, diagonally, obliquely, whatever you want to do it. The reason is that obviously there is Urdu, there is English in the schools. So obviously they have to read both ways. Okay, one more thing. Always try to give the patient instruction or training, because most of our population is using right hand, right? And we don't use our left hand. So what I do is ideally I train them with the left hand. If they have same binocular vision, and if you are going to give the telescope for the left eye, or if it is for the right eye, I just tell them now you have to use your this hand, left hand. Okay? So as you all are also, you should know use of left hand. It's important for being an optometrist, and all of us need to, because in the field, but the common people too need it, right? So you have to give them to train your left eye, take a help from this. So when they're using monocular telescope, they just keep them, look at the blackboard, okay, this is written, and they just write it with the right hand. Is not it easy? It's easy. We can encourage them. Yes, it is easy. We should always use positive intentions. Yes, I know it's very, very hard. It's very, very difficult to use binoculars, to use this, to remove, to move back. But in front of patients, you're no, you can do it. And yes, alhamdulillah, I have many, many patients. Alhamdulillah, they have got in the medical colleges. They have got in the Jinnah college for women. Pre-medical, usme kar rahe hain. Right, I have got students who have got job. Okay, one more thing is that most of our society, they leave their education just because of the vision. Right, now it's awareness month, I must tell you that whenever you receive such patients, always tell them your future is brighter than normal people like us or the other child which is normal. Right, जो आप उनके साथ जो मरीज़ है उसके साथ दो बच्चे आए हैं, एक नॉर्मल है और एक लो विजन का है, तो आपने उसको बताना है कि आपके इस बच्चे की जो मुस्तकबिल है वो आपके ये अच्छे सही वाले उससे ज़्यादा अच्छा है. रीज़न इज़ व्हाट? बिकॉज रीज़न इज़ दैट बिकॉज वो जब मैट्रिक कर लेते हैं या 9-10 के एग्ज़ाम देते हैं, so they have medical certificate, right? And I by myself provide them a certificate which they submit with their documents to the board, right? And they are given extra 30 minutes because it is in our constitution, it is in our laws, okay? As many of people don't know this, right? So they give 30 minutes extra to them, one thing. Second thing, if they are unable to read the small font on the paper, they are given a helper to read out this paper for them. So second advantage. The third advantage is if they are unable to write even due to vision, not due to dexterity or any other problem, but due to vision, that is, they will give a helper that he will read it out loud to them and he will write on. Right? Similarly, if we see we have halls, examination hall, and if you write it on it, he has problem with the sunlight. So he will automatically sit him in the dim light, in a corner of a room, not in a sequence which in a board is given. Right? So they will obviously place them in a suitable environment. Yes, if he need extra light, he will again set them in a better illumination. Right? So this is all there is and it's helpful. So what I do, I tell them to continue their education. They receive their blindness certificate or visual impairment certificate from Police Hospital Peshawar, right? And they submit it whenever they get a job, even they apply on quotas. Our quota seats go empty just because of this thing, because they don't go forward. Because there is no one to tell them. It's you and this is we will tell them. Right? So now I have two patients they have recently visited, so I remember they got a seat on the CT post nowadays to advertise with the government sector mein on the quota seats. And she's there was no principal in that school, so she's acting like a principal there, acting principal. And she comes to me and I will get really very happy. There is one female from Sawat who has RP, and she is in MBBS 4th year just because of these devices. Right? So what you have to do, they were about to quit their education, but this is you, this is the awareness which you brought, and now they are able to perform well. Second thing is that if nothing is possible for all those visually impaired, there are blind schools, and you have to be very, very good in counseling a patient or a mother or a father to admit your children in the blind school, and most of them don't do this. Why? Because if he is able to see the light, no light huwa takhkari ziran do kinachum khalak basawai. Again, it's you. It's you. You have to counsel them. I took 2 or 3 years on just getting them admission in the blind school. Nowadays, a patient come to me, and I think they are from Afghanistan. And what they is that even in Islamabad, they were told just get admit them in the blind school. And then she come to Mufarak Shah Saab, then again came to low vision clinic, and everybody is telling them just to get na mung bande da uskulu na khana razi. I don't know what does this mean. Zamu khanadan ke deta khana shikatale. So it's again a problem. Now she's trying for the video magnifiers to get them and so that he is able to read. So this is what all about the low vision seminars, right? Some of them are cheaper, so most of them. I would request you all that if there is one line improvement in the low vision services by simple refraction or spectacles, just give them that. At least something is better than nothing, right? If there is just a better fluency by reading the first line, no improvement, but fluency is better, reading fluency is better, just give them the spectacles. Don't go for no improvement, no significant improvement, because they are cheaper. One thing. Second thing is low vision management is a step-by-step process. It's not just you come and sit and give visual acuity, near, distance, and then you just give them and they are surprised. Oh, now I'm corrected for the distance, now for the near, and they are confused. Always tell them that's a step-by-step process. In first visit we will correct this, in the second we will do this, in the third we will do this. So it's always a systematic step-by-step process, right? So go for this. And second thing is that don't treat the patient, manage the patient, right? Okay, thank you very much.
थैंक यू सो मच मिस यमुना तारिक फॉर सच अ काइंड वर्ड्स. अब मैं दावत देना चाहूँगी अपने बहुत ही मोअज़्ज़ज़ और काबिल एहतराम CEO डॉक्टर मुश्ताक को कि वो यहाँ पर आएँ और आकर अपने ख़यालात का इज़हार करें.
मैं अपने ख्यालात का इजहार करूं या थैंक यू बोलूं सबको. बिस्मिल्लाहिर्रहमानिर्रहीम. माय डियर colleagues, ladies and gentlemen, assalamu alaikum. I would say many thanks to all the speaker who has made this day, Low Vision Aid Day, a very special. In FIO, say a very big thanks to our media team, Amir and Nigam, who has done a lot of efforts in a short time to make this day special. Low vision is, Dr. Ansa has already defined all those patients who has vision less than 16 or a visual field less than 10 degree. You know the 10 degree? Visual field less than means like a tunnel vision. Tunnel vision. He can see the vision very far. Like he can see, the patient will tell you that I can see in the mountains. How you can say that my vision is low? But when you do a visual field, he has only 10 degree or low vision, means a tunnel vision. So the tunnel vision means he cannot see even his footstep when he is going. So I would say a little bit about the low vision. Everything when a person have लोगों के साथ इसका वैल्यू नहीं होता, लेकिन ये है कि जब आपके साथ कोई चीज़ नहीं है, when you have a low vision, then you ask from those people who has a low vision. So all these patients are very depressed, and they are really needs a special attention. On our part, as a ophthalmic people, we have to give a special attention to all those patients whose vision is not corrected with all means from 6:18 upward, and all those patients who has a visual field less than 10 degree. So please, as Dr. Yumna has very beautifully insisted over, that all those patients are very, very depressed, and special attention is needed for these patients. And you will give them time as compared to the normal people or normal patients who has 6:6 vision. So thank you so much for making this day special, and this day is specially dedicated to our low vision patients. And hopefully we will means continue the tradition, and Amir is working over it. Every day he remind us that this is a special day, this is a special, like we have one day celebrated on Disability Day, which was very special day. So